Are you good now?
Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. Our topic is extreme dermatology, Dr. Leo Skorin. He completed his Doctor of Optometry degree at Illinois College of Optometry, and then his Doctor of Osteopathic Medicine, the Chicago College of Osteopathic Medicine. He did his osteopathic medical surgical internship in Tulsa, Oklahoma, and his ophthalmology residency at Michigan State University Metropolitan Hospital. He did a neuro-ophthalmology fellowship at the University of Illinois Eye and Ear Infirmary. He's also a Master of Science in Medical Education through University of New England's College of Osteopathic Medicine. He's an ophthalmology course instructor at the Edward Via College of Osteopathic Medicine in Spartanburg, South Carolina. And in my backyard, my former home, Nova South University's Kiran Patel College of Osteopathic Medicine in Fort Lauderdale. He is a board member, medical director of Mary Carmel's Light, which is the only United States nonprofit organization that supports patients with Charles Bonnet syndrome. Known Leo for a long time. He's a great mind, great lecturer, great clinician, and I think it's a great pleasure to be able to bring him. And Leo, take it away, and thank you so much for doing this for us.
Thank you, Greg, and thank you, Joe, for inviting me for this. I've done this for you a couple times in the past, and I've always appreciated and I've enjoyed working with you. You've done a wonderful job in introducing me. I was going to do all that myself, but thank you. I am basically functioning as a general ophthalmologist and neuro-ophthalmologist. And so the audience there is probably asking, well, what is he talking about dermatology and eyelid stuff? What does that have anything to do with it? I am not oculoplastics fellowship trained, but as my practice has evolved over multiple decades, I have wound up finding that I truly enjoy doing eyelid and periocular type of surgeries. And I do everything from minor lumps and bumps all the way to blepharoplasties, ectropions, entropions, dacryocysto-rhinostomies. I really found that that's something that I enjoy doing. And in my type of practice, I've been able to fully embrace all those types of surgeries, which we're going to cover. So the lecture I'm going to present, initially, we're going to do some introduction to the skin and some terminology. We're going to talk about the different type of biopsies that can be performed. Then we're going to talk about the lesions themselves, the benign ones, the pre-malignant, the malignant ones, and I'm going to sort of wrap things up with some surgical videos and some surgical procedures that I do that I've done. Some of them are much more extensive than most optometrists would really want to even get into, but this would be good, I think, for you to know what's going to happen if you have a patient with a basal cell or squamous cell. What are some of the surgical type of procedures that people do to remove that cancer from that patient? So we're going to get started here. I do not have any disclosures, any financial disclosures in anything I discuss. Okay, so let's just start with some basics. Skin anatomy. The skin is basically broken down into three major areas. You have your epidermis, which is the most superficial area, then the dermis, and then the subcutaneous or adipose tissue all the way at the bottom. So if you see this image here, can you see my arrow moving around?
Yes, you can. They can see it. Yep.
Perfect. Thank you. So this is the epidermis right here. So this is the corneum stratum, which is the most superficial area of the epidermis. Then you have your stratum granulosum, stratum spinosum, and then the germinal stratum is the deeper most stratum of all the layers of the epidermis. And these are rete pegs that sort of jet down into the dermis itself. And you don't really see the adipose subcutaneous tissue in this particular slide. The skin of the eyelid is unique to all the other skin in the body, is that it's the thinnest skin in the body. It's less than 1 millimeter in thickness, and it lacks subcutaneous tissue. So that is very important to understand and appreciate, because some of the biopsy techniques that we do are inappropriate to be used on the eyelids. That's one thing. And the second thing is you have to understand that the dermis is sitting directly on the muscle tissue. You don't have that adipose tissue, subcutaneous tissue, sort of as a dividing force. So if you're cutting deeper into the eyelid, you're going to potentially get into the muscle tissue. You're going to have much more bleeding and probably maybe some scarring and things like that. So you have to take all that into effect. And the muscle in the eyelids, of course, we're talking about is the orbicularis oculi muscle. So there are also epidermal appendages, that's what they're called. And these are basically glands that can be found in the skin surface, especially in the eyelid. There's the apocrine glands, and these are known as the gland of Moll or the cyst of Moll. These are hydrocystomas or sudoriferous cysts. That's another name for them. They're sort of sweat glands. They have sort of watery and oily secretions, and the ducts open onto the hair follicles. Then there's the glands of Zeiss, and these are a true pilosebaceous unit. This is purely an oily secretion. It's used to lubricate the cilia that the gland is always affiliated with. And then the final glands are the meibomian glands. And these are the modified sebaceous glands that we're the most familiar with because this is something that we encounter, especially in patients who have dry eye disease. So let's go through some some words here that we need to know, some glossary type of things. Let's start with macule. A macule, a perfect example of a macule, and probably every single person here that's listening to this has at least one of these, would be a freckle. So freckles are basically macules. They're non-palpable small areas of color change. If you look at your images down there all the way to the lower left, right here, this is a patient with erythema multiforme, and these are known as target lesions, and these are typical type of macules that you could see. Now, if you have the central image right here, if you have somebody where if you take your fingers and run it across the skin and you feel little bumps, those little elevations are known as papules. For instance, in rosacea, we would have papules. And these are palpable lesions. They're very small, about 1.5 millimeters or less in diameter. And these are the ones that you're just starting to not only see, but to start to feel. Now, if the papule is greater than 1.5 millimeters, then that's known as a nodule. And these are enlarged in height, width, and length. So this image right here is showing someone with a cancerous lesion. And you can sort of suspect that because the borders are blurred and you can see these little telangiectatic, like spidery blood vessels on the surface. Now, a plaque, such as something you could see in psoriasis, or is in our example here in xanthelasma, plaques are only enlarged in length and width only. So there's really no height. So if you take your finger over it, it'd be sort of pretty flat because it's down in the superficial dermis. We should understand the difference between erosion and ulcer. Erosions are just focal losses of epidermis, and that gives you a more shallow excavation. So for instance, here's an erosion in this photograph, microhistophotograph, and that's only involves the epidermis. So this, in those situations, most of these type of lesions, once you're resolved, they usually don't cause any scar tissue. But ulceration are always deeper ones. These involve not only the epidermis, the full epidermis, but also involve the dermis itself and maybe even further deeper than that. Here's an example of a lesion. It's got these pearly borders, this central necrotic area, so it's very deep. It's going down definitely into the dermis. And this would be a typical basal cell type of carcinoma presentation. Pustules are basically vesicles that have neutrophils, white blood cells inside of them. And a perfect example is this person's chin right here. This is acne vulgaris. So you have all these white heads, and those are basically the pustules. And then the other one I think we should understand are scales. So the skin normally desquamates every 27 days. The epidermis normally esquamates every 27 days or so. And if it doesn't, then it starts to look like this sort of plaquish type of scaly type of deposits left on the skin. And basically this is an example of squamous cell carcinoma on this particular patient. So during this presentation, I'm going to ask all of you to what I want you to become is to become osteopathic optometrists. Osteopathic medical school was an interesting experience in that they taught us that we have two tools with us all the time, our hands, and that we should use these hands as these tools in regards to any type of manipulation or touching the patient. So unlike my allopathic brethren out there that walked around with their hands in their pockets, the DOs were supposed to go out and touch everybody. So they taught us to experience the lesion, sort of say, with our hands and learn from that and get some information. And that actually is a great advice with specifically with the lesions that we would be looking at on the skin of the eyelids or the periorbital region. But first, you should stop, and before you stick the patient behind that slit lamp and put on super mag, take a bird's eye view. Get an idea of what the rest of the skin around that lesion looks like. Are there other lesions comparable to that one on the other side, on the other eyelids? You know, what's going on in the general picture. So you'll get an overall view, and then put it behind the slit lamp if you want and take a closer look. Then go ahead and grab that lesion and squeeze it, press it, stretch it. Is it mobile? Is it flocculent? Is it rigid, more indurated, hard? When you take it and you sort of stretch it and squeeze it, does the patient go ouch or totally ignore you? So that's a whole bunch of information that can come in for us as clinicians to get an idea of what we may be working with. So in becoming a osteopathic optometrist, you also should realize that you already have a lot of tools. Your optometric tools are ophthalmic tools that we can utilize to help make a good educated guess as to what this probably is, what you're looking at probably is. We had already talked about the slit lamp. That's great when you have the lesion on the eyelid or the eyelid margin. You can really magnify it, adjust the lighting in such a way so you can get an idea, of its breadth and depth. You should always photograph these lesions, especially if you're going to be following them. That's the best way to do it. Nowadays, we have cameras attached to our slit lamps, or even your cell phone itself would be a good way to take a photograph. And that's one way to document, is it evolving? Is it changing? Is it growing? So you could safely monitor it. A little trick that we were taught when I rotated through dermatology is to take like a +10 diopter trial lens. And if you have a lesion that you're not sure if it's a hemangioma or possibly some other lesion like a melanoma, you could take that lens, compress the lesion, press down on it for 30 seconds. And if it collapses and involutes, then you know you're probably working with a hemangioma, while any other solid tumor lesion will not involute at all and will basically maybe flatten a little bit, but overall maintain its shape and size. And then, of course, our transilluminators are great tools if you're trying to figure out if it's a solid lesion or if it's like a hydrocystoma, which is fluid-filled lesion. We can take the light source, put it adjacent to the lesion. If the light goes all the way through and the whole lesion sort of lights up, you're probably working with a fluid-filled cyst of some sort, maybe hydrocystoma. Greater chance that it's probably a benign lesion. But if it's a solid tumor, the light will have a shadow behind it. And then, you're saying, well, maybe we know it's not a hydrocystoma. We know it's not a sebaceous cyst or a cyst of Zeiss or something like that. It's probably something else that we have to maybe worry about. So this will be the first poll question. Do I read it or do you read it, Greg?
Nope. Go ahead and read it and I'll launch it. So,
okay. So the first poll question is, what makes an osteopathic optometrist? A, starts with a bird's eye view. B, knows that their hands are essential tools. C, uses instruments and tools that they already have in their office. Or D, all of the above.
And the polling question is open. You will not see it. The answers are already rolling in. Joe, are there any questions in the chat box?
Yeah, Leo, going back, you don't have to go back, but it was your first slide when you talked about papules and maculas. Somebody asked, what was the far left picture? What was on that person's hand and arm?
That was erythema multiforme. And those are known as target lesions. When you took a look at it, it almost looked like there's little bullseyes in them.
All right. Well, I think the trend is set here. We got people rolling in. It doesn't happen that often where you get 100%. So I'm going to display it before someone decides to change it. You've got all the above, D, at 100%.
And that is the correct answer. You have one heck of a smart audience out there. Okay, so we're going to move on. Is that correct?
Yep, you're good.
Perfect. Okay, so working on that same theme of using your hands as tools, as instruments, and helping in the diagnosis of what you're looking at, you can also do lymph node evaluation. Remember, they taught us back in school that the lateral lid drains into the preauricular node, which is anterior to the ear, and that the medial lid drains into the submandibular node, which is below the mandible, when you go ahead and basically palpate there and see if you feel any of the bumps. So that could tell you if there's an infectious etiology, if it's some sort of inflammatory etiology, something like that. So don't forget to also palpate for any lymph nodes if you have a suspicious lesion. And then finally, we're going to sort of wrap it up here a little bit with some definitions. We're going to just talk about the A, B, C, D, E of something that we were all taught in school of differentiating between a benign and a potentially non-benign malignant lesion. So the A is asymmetry, lesions that have an irregularity to them. They, have multiple bumps. They seem to spread in different directions, things like that. That would be asymmetry versus a simple domed lesion, which is more asymmetric. You'd be more suspicious for malignancy. Are the borders irregular? Are they blurred, sort of ragged looking? Are they spilling into the surrounding skin, even though that surrounding skin may look normal? That also increases our suspicion. Does the lesion have multiple colors or shades of a single color? Usually 3 or more is considered increased chance of it being a malignancy. Obviously, the larger the lesion, the more suspicious it is versus smaller ones. The cutoff is the 6 millimeter rule. That's the size of a pencil eraser. Basically, anything bigger than that, you would consider that it might be a malignancy. And then getting information, gleaning information from the patient. Does the patient come in and tell you, I've been noticing it's getting larger, or the shape is becoming more irregular, or they're starting to feel it when they're touching it, it hurts, which it didn't hurt before. Is the surface becoming more friable? Is there more color variation? So that's the E, or the evolving. So we should all know our A, B, C, D, E's, and actually even teach our patients this if possible, so they can watch for other lesions elsewhere on their body. So other suspicious history would be if they've had previous skin cancer, if when they were younger, did they have a lot of sunburns, especially blistering type of sunburns? That increases the risk. There's probably less patients that have had radiation therapy for acne. There might be still some out there. They would be in their 80s or 90s at this point. And of course, those individuals that are Celtic or Scandinavian ancestry, patients with red hair, fair skin, blue eyes, they get burned, a greater chance of getting burns more often, blistering types of burns. And so if they're out in the sun, especially if they've had a long history of it, then that increases their risk of having more suspicious lesions. is the lesion growing or changing in shape? We sort of talked about that earlier too. Induration is an important concept to remember. Induration just means a thickening and a hardening. There's a firmness to the lesion. That's where your hands come in. You know, if you're feeling it, it feels like hard, like a rock, that's a little suspicious there. Do they have those abnormal blood vessels, those spidery-like blood vessels on the surface? We saw an image of that earlier. Those are known as telangiectasias. The classic pearly borders that we see with basal cell carcinomas, that's also suspicious. And one of the main things is if the lesion is on the eyelid margin, does the eyelid maintain its integrity, the margin maintain its integrity and its structure, or is it being totally disrupted? Is there notching? Is there now irregularity? So usually some sort of malignancy would wind up causing destruction to that eyelid margin. And in the same vein, if it's invading also the hair follicles, the cilia follicles, it's destroying those follicles, which leads to eyelash loss. So that patient would also have what's called matarosis in the same location. So eyelid margin distortion, matarosis, all highly suspicious for a malignancy over a benign lesion. So let's do a quick case here. This is one of my patients, 76-year-old white male. He comes in with his wife. He has this recent onset lesion on his right by his eyebrow, lateral eyebrow, and you could see it right here. It sort of has a little necrotic center type of thing, and it's definitely elevated. And he says the reason he's actually coming in is that he's noticed that now when he touches it, it feels like he has a thistle in his eyelid. And if you know what thistles are, they're like these pointy type of plants, and when you touch it, they like poke you in the finger. And so every time he touches it, it feels like something sharp is poking him right over the lesion. So he has a past history of skin melanomas. Okay, so that's not good. So that increases our potential for this being a problem. So basically what you see here is I used a surgical marking pen because I took him into surgery to do an excision. This is called an excisional biopsy. So that's one of the procedures that you can do in and around the eyelid area. Of course, anywhere on the body, but for our purposes, you could do it on the eyelid or the periorbital area, no problem. So an excisional biopsy is, it's important for two things. One is it'll give you the diagnosis of what the lesion is, because you're going to excise the lesion so the pathologist could look at it and tell you what it is. And hopefully it's also curative in that you've taken all the lesion out so that there's no chance of it for spreading. And so what you're going to do is you're going to go about 1 to 3 millimeters outside into the areas of where the normal skin is beyond the border of the lesion. And that's the area you're going to mark. And usually you do it in, this type of elliptical fashion, because that's the easiest way to put it back together once you excise that area. And so basically I excise around the lesion this way, and I go deep. In this case, there will be subcuticular tissue because you don't know how far down the lesion is extending into the dermis and beyond the dermis into the subcuticular area. So you basically want to take all that out. And when I sent it into the pathologist, the pathology report did come back that it was squamous cell carcinoma. So it wasn't a melanoma, but it was a squamous cell carcinoma. And why this is sort of an interesting case is that I remember in medical school back in the 1980s, we were taught that cancerous skin lesions are not painful. But recent studies have shown that actually squamous cell carcinoma in about 40% of patients will develop some sort of pain over the lesion when they manipulate it. In this case, he had this sharp thistle-like sensation. But it also confirmed that basal cell carcinomas, patients don't feel pain with those. So that's another sign here for me or I should say symptom for me, for the patient, because he's telling me he's feeling pain with this. And that makes me think more squamous cell carcinoma. So let's talk about biopsies, and then we're going to do another poll question here. But
Actually, Leo, I have a personal question for you.
Sure.
Based upon your extensive experience, when you look at these lesions that you're going to biopsy, how often do you get surprised with the results?
um, maybe 30% of the time, 40%. Okay, 50%.
I would have bet 20%.
Yeah, I don't know. I think you know, the longer I've been doing it, probably the percentage is less. But you know, sometimes it is very surprising what it comes back at. You know, obviously, if you're doing a chalazion excision and all this purulent pus squirts out all over the place, I mean, that's a pretty simple diagnosis. That's 100% of the time you're going to get it right. But on these types of lesions, I knew that this was suspicious because he was, it doesn't look right. It's been growing, it's more recent onset, and he has this past history of melanoma. So I knew, I probably would have thought this was a basal cell, but it came back squamous cell. And because of the newer literature, I should have known that it was probably squamous cell because of the pain differential. And that's what I wanted to bring up in this particular slide. So when it comes to biopsies for the eyelid area, or the skin, I should say, there are basically 3 different types that you can do out there. The excisional biopsy, that's the one I had just shown you in that particular patient we were talking about. Here you're trying to remove not only the lesion, but at least 1 to 3 millimeters of a normal border around it. So in other words, you're trying to get all of it, and so that the pathologist can tell you you've got it all and you don't have to go back in. If you look at the lower left image, you can actually see this is what I removed from that gentleman. It's flipped upside down. You're looking at the subcutaneous tissue right here. But why I'm showing this is for 2 reasons. One is, you notice I have a silk suture here that I've attached to a section of the lesion. And the reason I've done that, I've done it for orientation, not only for the pathologist, but for myself. So this is in the superior quadrant, of the superiormost edge of the lesion is where I put this one suture. And this is how I will send this specimen in formalin to the pathologist. Because when the pathologist checks all the borders to see if I got the whole lesion or if there's some involvement, if I didn't mark it and he says, yes, you do have involvement along one edge, I can ask, you know, they'll tell me it's on the opposite side, let's say, from where the suture was. So I know that when I have to go back and take more tissue, I don't have to take it everywhere and make the hole even bigger in the person's head. All I need to do is take some in the inferior edge and send that specimen back in for them to check to see if I got all of it this time or not. So it's very important to mark these specimens. Otherwise, it's totally disorienting and you will not know which way is up, essentially, and neither will the pathologist. Some people will put like 1 suture in one end and 2 sutures at the other end, and maybe 3 on the medial wall and 4 on the lateral wall, and then they write it all down. And this way, it gives even more information to the pathologist. I don't have time for that, so I usually don't get that intricate. The other thing I wanted to point out is this handle. This handle here is actually the blade that I use, the Bard Parker blade that I use. This is one of the disposable surgical blades that you can use. And and even the non-disposable ones where you have a handle and you just put the sharp cutting edge onto it, they all usually have a millimeter ruler on the handle of the blade. So this way you can measure out the diameter of what you excise. Now you're going to say, what does that matter? It matters when you're billing, because the size of the lesion, you have to document that. And so obviously the larger the lesion, the higher the reimbursement code you can use for it. So that's why I'm mentioning that part of it. Now, shave biopsies are also something you can do on the eyelid very well. I do a lot of these. So let's say you have something on the eyelid margin that you want to remove, and you're not sure if it's cancerous or it's benign, but you just want to get an idea. It's on the eyelid margin. Are you going to go ahead and just take a big cut swath out of that and send it in? And then you're going to leave a giant notch in the patient's eyelid. That is not going to recover. It's not going to look good cosmetically, and it's not going to function well. The lid's not going to function as well, especially the normal distribution of the tears, etc. So a shave biopsy is perfect, especially if you're not sure what you're working with, and it may be totally benign. You don't have to do any more. And that is using like a number 11 Bart Parker blade. So all the blades come in different numbers, and that tells you basically if you're using it for finer tissue or broader tissue. And I essentially shave along the border of the eyelid itself to remove just the dome part of that lesion. And that's what I sent in. That's what I send in. It doesn't matter. I don't really mark it because it doesn't matter. Because if it comes back malignant, I'm going to have to do a more complicated surgery on that. But if it comes back that it is a non-malignant, it's benign, I may be done. I don't have to do anything. And I haven't disrupted the eyelid border margin at all. Now, you do have to apply a little cautery, usually handheld battery operated cautery unit, just to the area where you did the shave, because that will cauterize a little feeder vessels that were making the tumor grow in the first place. And so hopefully you've eliminated any further growth in that area. Then the final one that I want to talk about is the punch biopsy. And these are all the punches, this imaging here on the right. They come in different diameters. You always want to get a punch that's 1 millimeter larger than the lesion that you're going to remove, because again, you want a millimeter or so of normal tissue around it. And these punch lesions, you're going to put perpendicularly onto the skin surface and essentially twist it and push down so you get a conical type of excision. So basically you're going through skin, epidermis, and subcutaneous tissue, and then you grab the tissue and just cut it at the base, and that's your specimen. So this is one you would never use on the eyelid. Why? We don't have subcutaneous tissue. If you were to try to do a punch biopsy on the eyelid, you're going to go through skin and dermis, epidermis and dermis, but what's beneath there? Muscle tissue, and further than that, the eyeball. So you would never want to use a punch biopsy, and it doesn't work well on the face either. This is used like on the back or on the arms or legs, because then you got this circular lesion and you have to put a suture through it, and always looks either involuted or it looks, there's some scarring, things like that. So it's not a very elegant way to do a biopsy in and around either the eyelids or the periocular area. So I've used punch biopsies, but never ever on the face or the eyelids. You would use it elsewhere. But excisional biopsies and shave biopsies are great for eyelids and periocular lesions. Okay, poll question number 2. And the question is, have you ever performed a biopsy on a patient? And it's either A, yes, or B, no.
Polling question is open. Joe, do we have any further questions?
I think we're good.
So, Leo, do you biopsy just about everything you remove, or is there certain things that you don't? Or is that just a practice that anything you cut off, you send for a report?
I was more that way when I first started, doing these, because I wanted to learn and find out what it is I'm removing. But certainly when you get to simple things like skin tags, chalasia, things like that, I just can't justify the additional pathologist cost for the patient. So the answer is no, I don't. But if you're starting out, you should definitely do that because that's how you're going to learn what it is. It sort of goes back to Joe saying you might as well guess what it is because then you'll find out how good you are at guessing, and you'll find that over time you'll get better and better. And the only way you'll know if you were right is if you send it in.
Well, you know,
Yeah,
there is that philosophy that says lumps and bumps belong in jars, not in faces.
Right. And again, it also depends how much you're afraid of lawyers, I suppose.
I
And that
kind of
goes,
suspected when starting you'd probably be a little bit more cautious, and then as you did learn, you would figure out to try and help keep the costs down, that it would be minimized. So I just have heard people say, "Oh, you got to send everything in," and I think a skin tag that you take off that's pretty straightforward, does not need to be biopsied, but.
right. I mean, the other thing is you can always tell the patient, look, if it comes back for some reason, come on back and see me. And then if I had to do it a second time, I'm definitely going to have to send it in.
Perfect. All right, so here we go. We have 3% that have performed a biopsy, and we have 97% that have not.
Okay. And it sort of matches what your earlier poll was.
Yep.
Okay, so we're sort of done with just terminology. We're done with the type of biopsies. Let's look at the lesions themselves. We're going to start with benign, go to pre-malignant, and then progress into malignant. And we're going to finish up with the surgical part of it. So sebaceous cysts are very common cysts. These are always benign. Just to show you different patients I've had, they look different. And this is where coming in, like let's say this image on the right, you can actually, and I know it, because you can actually take this little sebaceous cyst and sort of pinch it between your fingers. First of all, the patient ain't going to feel anything there. And second of all, you can actually move it around and you'll notice that it's mobile because it's not affixed to the deeper tissues, essentially. And here's a second sebaceous cyst. This one probably not as mobile, but you're going to look at these and you're going to say, well, they're more cosmetic than anything, but not really. You want to code it as these can potentially cause problems in the nasal canthal area, could affect the normal flow of tears. They may get the epiphora. They may have other kinds of problems. Sure, they're cosmetic also, but the justification is that they can definitely affect the normal architecture and how things work in that particular medial canthal area. So these have to be completely excised. You have to have the whole capsule removed. Otherwise, it can come back. Now, if you have like a crop of these on the eyelid, these are called milia, and also known as kernels of rice. And there's all kinds of little ones here. I usually do these in a staged procedure because if I go after and try to get them all out at one time, I think what's going to happen is their eyelid's going to look like I've just tenderized meat or something like that. It's going to look terrible. So you take out about a quarter, half of them, let it heal up. Again, they're benign, nothing, you don't need to rush around to get them out tomorrow. And then they can come back. You could take out another section of them, etc. And their eyelid will heal better and they won't look as frightening afterwards and it won't be as painful for the patient. Cysts of Zeiss, remember these are the true pilosebaceous units. So here, if you see one, it'll always be along the eyelid margin. There's always some matterosis here because that follicle is involved and destroyed, but it's not the type of matterosis that you would see with patients that have like a more malignant lesion, like a squamous cell or something like that. And here you might as well, you're going to have to take out the whole thing. Tell the patient that eyelash will never grow back because basically it's already destroyed by this particular cyst anyway. And with your excision, you're going to wind up excising the follicle also. It's non-functional. So let the patient know ahead of time because they're going to look at themselves in the mirror all the time. They're going to see that gap. It's going to be missing. And basically you've warned them ahead of time. Cysts of Moll, other benign lesions. I see lots of these. This gentleman here has 2. This lady finally came in. I mean, look how gigantic this is. Finally she came in because she noticed that when she looks to her left. I guess in this case, she couldn't see the oncoming cars anymore from when they were trying to cross traffic. So she decided that she wanted it removed. And like this was another one that you've seen before. And these are the ones that are great to transilluminate. And you'll see the light going straight. They light up like a little Christmas tree, like a little red light bulb, and the light goes straight through them. And you know you're working with assistive mall. I do know one optometrist in my area, and she loves to continue to poke these things with a needle to drain them. They will drain, but as soon as that little area heals over, guess what? They come right back. So you do have to excise the whole thing. You have to get the whole sac and removed, or they will just keep on coming back over and over again. Don't just poke them and expect them to be gone. That's not how it works. Xanthelasmas, we had talked about those already. These are these lipid-laden macrophages, and they're located in the superficial dermis, so they're right underneath the epidermis. If they're young patients and it doesn't make sense, maybe send them in for a cholesterol workup, triglyceride workup, etc. Supposedly, there's some deep extension in some of these. I have been removing these for 40 years. I have never, ever run into that. They're always very superficial. They're usually located in the medial, superior, or inferior eyelid areas. That's where you usually see them. I like using chemical cauterization or dichloroacetic acid, basically, to remove them. What you do here is you don't have to numb them up. It's going to burn when you apply the acid. But if I was going to go ahead and inject lidocaine, guess what? Lidocaine burns too. So I just tell the patient, look, this will burn for just seconds and you'll be perfectly fine. So I do put topical anesthetic in the eye in case there's any vapors from the acid. I don't want them to irritate their eyes so they start tearing. Then I'll take petroleum jelly. It usually comes in the kit. And you want to put petroleum jelly generously all around the lesion, because when you apply the acid to the xanthelasma itself, if some of the acid is to bleed in the periphery, you'll get into normal skin, and you don't want to do that. So within 30 seconds or so after you do that, you're going to start noticing that the epidermis is going to turn into this white type of circle around it, and you're going to start seeing a melting away of the lipid in those macrophages in the superficial dermis. So when you start seeing this sunny side up egg like this, you're done. You don't have to do any more. Usually I wait, a minute or two, and then I remove the petroleum jelly. I usually write them either for bland ointment or for erythromycin antibiotic ointment. You don't even have to really pre-sterile. I do an alcohol wipe, but you don't have to really go out of your way to do betadine or anything, because this is acid. Once you apply the acid, you're going to kill any bacteria or viral elements that might be on the skin surface anyway. And then afterwards, I've never had anybody ever get an infection, but you could have them use antibiotic for a week, antibiotic ointment for a week, twice a day or so. That's just to lubricate it more than anything else and preventing maybe any secondary infection. And then about a week later, this is what they're starting to look like. And you see the skin is starting to re-epithelialize. It'll re-epithelialize beautifully, not leaving any scar tissue behind. And if you had left, let's say, some of the petroleum jelly bled over into the area of the lesion, you can, after it heals up, you can bring it back and do a little touch-up, just like they do in LASIK. This will be just a little touch-up. You could call it a little touch-up. I never charge them for the second visit if I have to do that, but usually you get all of it at one time. Now, this does not work for blacks or Hispanics or anybody who has a lot of pigmentation, because then it'll leave like a white plaquish area behind. It'll be like a white area that will not pigment in. And so you can only, it doesn't work for them. For those individuals, you have to, basically do an excisional type of procedure for these xanthelasmas. It will be a lighter area on the skin, even on white patients, but eventually when they're out in the sun and get some UV exposure, it'll start tanning, and before you know it, it looks just like normal skin around them. Now, This is from Nate Lighthizer. It's in our book. I know we're not supposed to promote any book, but the videos are from there. And if you wanted to see more videos, they're there also. And this is basically using radio frequency surgery. I don't have one of these units, so I don't use it. But here you will have to go ahead and numb up the area with usually xylocaine with epinephrine. You can see the xanthelasma there. And the radio frequency unit, these things work like electrocautery, except that the electricity goes through the body, and then the resistance is actually at the level of the tissue itself. So unlike electrocautery, there's no lateral spread of the electrical current. And you can see the area's been numbed up, and this is that curved tip, and it's basically applied. These are usually like 90% ablation and 10% cautery. So the advantage here versus just doing an excisional biopsy and removing the xanthelasma surgically, you can apply this. You have to remove the dermis. It has to be wet, moist. So the Q-tip they're using has saline on it. And you can start seeing the superficial dermis here because you can see the xanthelasma cells themselves being exposed here, those lipid cells. And so you basically just remove the epidermis and then only the superficial most area of the dermis itself. Okay, so and you just keep on going until you get all of it out. And again, same thing, you put antibiotic on it and essentially you're done. So we're going to move on here. Other benign lesions.
Actually, Leo, before you get too far, a number of questions came in.
Sure.
Oh, let's see. You're commenting on some of the other surgical adjuvants. You didn't mention Imiquad yet. I'm sure you might be. Are you going to be talking about any of the other adjuvants to surgery? What do you want to talk about? Imiquad?
I'm going to be talking about some of those oral products and things like that a little bit later.
Okay. Question is, can milia be treated with a laser? Or what treatment is there for it?
Milia treated with a laser. Well, they're sort of intracutaneous type of sebaceous cyst. So I don't think it could be treated with a laser. Those you basically have to excise them, just like you would any other type of sebaceous cyst. So I don't know of using any type of laser on that.
And what can you prescribe for eyelid eczema that won't cause lid thinning?
I don't know.
Okay.
Fair
enough.
I've never had to do that.
Fair enough.
You know, if I really have something tough like that, I'll just send it to the dermatologist.
Okay.
Sorry.
No worries. Good.
Okay.
We're caught up.
The nevus is another, lesion that could look suspicious for some other malignancy. Like for instance, this particular lesion on the eyelid margin, inner eyelid margin, definitely looks, suspicious, like for a melanoma. The only reason why you may think it's not that is it's got sort of a uniformity to it. It doesn't have a lot of color variation. And the other thing is there's no matarosis. Look, all the eyelashes are intact. Now, this would be a perfect lesion to do a shave biopsy on. I did not think it was a melanoma. If I thought it was a melanoma, I probably would not even do that. I would send it off to oculoplastics because they may want to do like a Mohs procedure on it. But in this case, I thought, these kind of lesions look pretty much like nevi. And so doing a shave biopsy saves the patient, going to another doctor and potentially having something more involved, as long as it comes back that it is nothing more than a nevus. And again, because all the lashes are intact and it looks pretty uniform, I would say that's what it is. But I would definitely do a shave biopsy on this. If I thought it was a melanoma, I would definitely send it off to oculoplastics. Molluscum contagiosum is caused by a pox virus. And I've seen this usually in kids. They could be on the eyelid margin, but they could be anywhere else. So they get one of these lesions, they'll start scratching on it, they scratch elsewhere, and then next thing you know, they're spreading it all over their body. If they're siblings or cousins and they're sleeping in the same bedroom, next thing you know, all of them have it. So it does have to be surgically removed. And usually the key here is it's usually a child coming in, and they have them elsewhere all over the body also. Then it gives you a good idea that it's a molluscum contagiosum. Like I said, they all have to be removed. Usually a curette is sufficient to help take care of that. This one along the lid margin would cause maybe a viral type of conjunctivitis. Now, skin tags or verruca are very common, and something, if you're first starting to do these kind of procedures, this is a great place to start. It's simple to do, and they're easy to take care of, and you're working really with benign lesions, so you're not gonna miss anything much on this. There's two types of verruca. There's verruca vulgaris. These are pedunculated and have a stalk. So usually they sort of stick out like this one is doing here. And we're going to show you just another excision of one. So there's a little, let's start from beginning. So the lid's been injected with a xylocaine, lidocaine, and you could see you just sort of grab it, tent it superiorly, tent it away, and then cut it off with Westcott scissors right at the base. You could use radio frequency on that also if you wanted to. You can even use dichloroacetic acid, but just a simple excision is good. Don't forget to apply a little cautery because you want to get the feeder vessel so it doesn't grow back. And then whether you send it in or not, if you're not comfortable or you're just starting, I would definitely send it in. The other type of verruca is verruca plana, and these are more sessile. So they're sort of flat and they're more broad based, and they sort of look like they're stuck on. And this one is on the eyelid margin. And this would be a perfect one to do a shave biopsy on and then apply cautery to the eyelid margin after you've anesthetized the lid. Same thing here. I wouldn't do a big excision on this. I would try to do a shave, a biopsy along the surface here laterally and just basically remove the whole lesion. And this is one of a patient on the eyelid. You can see right there. Now,
clamp on here.
So there's a clamp. This is a chalazion clamp being put on. And this clamp basically steadies the lid, makes it easier for you to excise it, also causes hemostasis. Because the first time you cut into that, you're going to get a squirt of blood, and then it's going to obscure your ability to do further cutting. And also prevents you slipping and cutting the eye beneath there. So it acts for some protection. So in this situation, it's not a shave, it's sort of an elliptical excision. And this is what's called a number 15 Bard Parker blade. So they come, like I said, for different depths. And here what's going to happen is you're going to wind up, you're going to notice that it's difficult with these Westcott scissors to excise that. So you're probably, the best thing to do here is probably to grasp the lesion and sort of pull on it and then excise it. You could take the clamp off or leave it on. Here it looks like the decision was made to remove the clamp because it's sort of getting in the way. And you're going to notice that it's not bleeding because you see there's a little bit of a crush here to the tissue. That will all resolve on its own shortly, but it maintains the hemostasis. So essentially you're going to excise it. In those kind of situations like this, I probably send that specimen in because it's got a discoloration to it. It was on the eyelid margin. You want to make sure you got the whole thing. Larger.
Hey, Lil, somebody asked, can you freeze these off? Can you do freezing therapy?
You could do cryotherapy, but I would not do it on any of the lesions on the eyelid margin, because with cryo, you could get spread of the laterality, like we were talking about, like electrocautery. You could get laterality and spread to normal tissues around it. So you don't have as good control of how much you're actually removing or getting rid of. With cryotherapy, you're just getting rid of it. So I would not, definitely not use it on the eyelid margin. Sebaceous or seborrheic keratoses, I see a lot of this on older patients. They look like these also like sort of stuck on lesions with these broad base. They're sort of sessile. They could be pedunculated. And these are always benign, but you know, you don't know exactly what you're working with. So it's a good idea to excise these and send them in and just to see what they are. This would be good for a shave biopsy. All of these actually would be good for a shave biopsy. You just want to get at the bottom and get the base out. Cutaneous horns are sort of interesting. This is keratinization that occurs usually in the eyelid areas or the facial area. I've seen that they could be anywhere on the body. But the question here was, in the past, it was always thought that, well, cutaneous horns always only grow over things like benign skin tags. But we know now that that's not true. There is a chance that it could be a malignancy that is the underlying etiology that's causing the cutaneous horn. So you want to make sure that you do a pretty good excision of the area around it in case it's squamous cell or basal cell carcinoma. And so 65% of them will be benign, but up to 15% can be malignant, with squamous cell carcinoma being the most frequent of all the particular malignancies. And so you do need to send all of these in for histopathologic examination. So used to be we'd never send them in. Now we send all of them in. So let's do a quick case. 85-year-old white male comes in with his wife, and basically she sort of drags him in because she's sick and tired of looking at this thing on his lid. He said that it started growing several months earlier, so it's a recent type of lesion. It thinks that it hasn't really changed much recently, so it sort of came on quickly but hasn't evolved that much. But when you look at it closely, you could see the cutaneous horn. But what's the underlying pathology? And look at this. I think if you look at it, it looks like the lesion's actually extending way over here. It's not just in this one area. The other thing you should see here is, look, there's notching of the eyelids. So the architecture is being disrupted. And where's all the eyelashes? And the eyelashes that are there look sort of funky. You know, they don't look like normal eyelashes. So obviously there's some matarosis going on here too. So basically, I do have I think a poll question here. Do you suspect this particular cutaneous horn of this patient to be either benign or malignant? So A is benign, B is malignant.
And the polling question is open and the answers are rolling in. Joe, are there any questions?
No, we're caught up.
Give it another second or two here and answers are rolling in nicely. Okay, I'm gonna give it, they're still changing. All right. We've got 73% going with malignant.
Well, I would, my suspicion was actually the same thing, malignancy, because it was sort of a new onset lesion. The eyelid margin architecture was being disrupted, and the patient obviously had matarosis. I didn't complain of any pain or anything like that. And he has a cutaneous horn. So I know this will have to be sent in. And I'm going to tell you, I did not do anything with this patient except send him to oculoplastics, because that looked like that is going to be a very complicated procedure. And they actually wound up doing a Mohs procedure on that patient. and it did come back as squamous cell carcinoma. Now, did I know it was squamous cell? I didn't, but I suspected it might have been squamous cell carcinoma. And this is his initial report, and you can see the deep margins were involved, so they had to keep on going and doing more and more surgery on this patient to do a complete excision of and reconstruction of this particular lesion. So we're done with most of the benign lesions. I don't know if I got all of them, but I think I got the vast majority of them there, and especially the most common ones. So let's talk about pre-malignant lesions. Actually, if you think about it, cutaneous horns should also fit into pre-malignant lesions, and they would fit in here very well. But one of the ones out there that was also another one that sort of changed from the 1980s to now are keratoacanthomas. I've seen maybe, 24 of these in my 40 years that I've been practicing. So they're not super common, but if you look at them, they look like they could be basal cell carcinomas, every single one of these. But there's a big distinction. The distinction is that they come on rather quickly. Basal cells can take months or years to sort of evolve, while these things in 3 to 6 weeks, that's what they look like. So basal cells will not do that. Plus, this is seen in younger people, not older people. Everyone I've seen has been probably under 40 or under 45 that has come in with these types of lesions. And we were taught back in the 80s to do nothing with these things and just watch them because most of them involute. And I'll tell you, the first decade or so before the new information came out that these could be actually have an underlying malignancy like squamous cell carcinoma, I did exactly that. I did nothing except just watch them. And every single one that I had, that's exactly what it did. By 6 months, they were all gone and looked perfectly normal. But today, I would definitely excise these and send them into pathology because we know that there is a small percentage, but some of these do have an underlying squamous cell carcinoma that sort of initiates this particular keratoacanthoma lesion. So these would be considered pre-malignant. All of them need to be sent in. Another very common one is actinic keratosis, also known as solar keratosis. And these are these scaly, firm lesions seen also in the elderly, those that have been exposed to a lot of sun. And these, unlike seborrheic keratoses, these can, about 2% will evolve into squamous cell carcinoma. So they're sort of the form thrust of the squamous cell carcinoma. Now, I'll be honest with you, when I look at these patients, I can't really tell the difference between sebaceous keratosis and actinic keratosis. To me, they look the same. And probably some of these patients have one of each or 10 of each or whatever. And so I wind up trying to excise all of them, and I send all of them in because I just don't know which one it is. That's one of the ones, Joe, that I cannot tell the difference. I'm usually wrong. Whatever I guess, it's usually the opposite. So here's where they look the same to me, and I just still haven't figured out how to tell the difference. Now, let's talk about some malignant lesions of the eyelids and eyelid areas. And basically, the one that's the most frequent, 90% of all eyelid lesions, is basal cell carcinoma. We've already sort of talked about them a little bit, and we've seen them. They're all of these lesions are usually a consequence of some ultraviolet light, prolonged ultraviolet light exposure. Basal cell carcinomas are most commonly found on the lower lid and in the medial canthal area. So this is usually where you see most of them, but of course they don't all read the book, and so they can occur anywhere. Chance of metastases is very small. This patient, as you can see here on the right, this is not an eyelid. Here's their ear. This patient actually came in to see our optician because the glasses that he was wearing, he said that temple, something's not right with the temple in his glasses. It's irritating behind his ear and it's rubbing against his skin. And so the optician, they took a look, and next thing they know is they see this particular lesion and say, no, you got to go and see our ophthalmologist. This is not a glasses issue. This is something else. And this is a typical basal cell carcinoma with the pearly edges, the central necrotic area. You're going to say, why is it necrotic centrally? The tumor is growing and it's outgrowing its central blood supply. So the tissue is just turning necrotic in the center, and that's what you're seeing. And basically, the end, when I put his glasses on, you could tell that the very end of the temple was literally sticking into this particular lesion. So that's why it was irritating him. In a rural area, the area around me is very rural. I can actually see cornfields if I look down the particular street down my block. And so I have a lot of farmers that see me. So all these farmers protect themselves by wearing their baseball cap, their John Deere baseball caps on their head, which means that the back of their neck and behind their ears is exposed to sun for years and decades on end. And so I've seen lots of these types of squamous and basal cell tumors on the back of necks and behind the ears and all that. So these are actually very common, especially in the rural areas where you have a lot of farmers that are out in the fields all the time. I have another poll question, Greg. The previous basal cell carcinoma lesions look like small bites from a particular animal. Therefore, these lesions have another common name. What is that name? A, cat scratch fever. B, elephantiasis. C, rodent ulcer. Or D, hoof and mouth disease. Notice they're all animals.
The poll is open. Answers are rolling in. Joe, any questions, any comments?
Nope, there's a question, but I handled it.
All right, looks like things have slowed down. Looks like we have a majority of the people weighing in. So we have cat scratch fever at 13%. We have rodent ulcer at 80% being your winner. And hoof and mouth disease at 5%. So 81% is your rodent ulcer.
Yeah, when I wrote this question, the first three I thought of right away, and the fourth, I said, I got to come up with the fourth one. And my wife heard me mulling around. She goes, how about hoof and mouth disease? I said, that sounds great. Sounds like a horse or a cow. The answer, of course, is rodent ulcer. We'll go back to this image here. You can definitely see, I honestly don't know how many people get bitten by mice and rats, but maybe in the old days when people lived in shacks or they lived in huts, these little animals would crawl in and bite you. And I suppose this is what the bites look like on your body. So that's where the term rodent ulcer comes in. It's supposedly bites of mice or rats when they're eating you while you're sleeping. And so basal cell carcinoma is broken down into either nodular basal cell carcinoma, which is the most common one. And you can see this rodent ulcer here with these pearly edges, the central necrotic core. And this is one of these deep ones. This is an ulceration. That's why it's called a rodent ulcer, because it's going through the epidermis into the dermis layers. So it's deeper than an erosion would be. And this one on the eyelid margin, you can see those spidery little blood vessels. Those are the telangiectasias, which are also commonly seen on the surface and the edges of these particular rodent ulcers. Then you have less commonly what's known as diffuse morpheaform basal cell carcinoma. And it's only about 15%, and it's causing this sclerosing or induration. So in this particular image, here's the eyeball, there's the cornea, here's the conjunctiva sclera, and here's the eyelid margin. When you first look at it, it's hard to tell what's actually going on, but this is the eyelid margin. You could see the cilia here. You could see the telangiectasias. Obviously, the architecture of the eyelid margin is totally distorted. Remember, that was one of our criteria of possibly this being a malignancy. The telangiectasias was another criteria. And the third criteria was what's missing? Lashes. So whatever this tumor is here, this is particularly with morpheaform basal cell carcinoma. Essentially what it's doing is it's destroying the underlying hair follicle, so the lashes fall out. You have what's called as matarosis. So you could get ulceration with this, and it's indurated. So if you were to feel the lid, it would just feel extraordinarily rigid and hard. And it can sometimes mimic scar tissue if somebody's had an injury before. So you have to be careful with these in regards to making the right diagnosis. The other thing is, if you look at this, you can't really even tell where the edge of it is. You're going to say, well, maybe the edge is here because the lashes are present, but no, there's definitely distortion here. So these are the type of lesions like this that I would send to oculoplastics, because it's going to need a major reconstruction, probably with Mohs procedure, Mohs procedure excision, and then a major reconstruction afterwards. So this is a patient that I saw during my ophthalmology residency at Michigan State University. This guy comes in with his wife, who says she's finally sick and tired of smelling this thing. I was going to say, where along the way did you get sick and tired of looking at this thing growing on this guy's face? There's his upper eyelid. Can you all see that? That looks intact. Eyelid margin looks intact. So this is probably a benign lesion, right, Joe?
Yeah.
But oh my God.
You might want to get that looked at.
Yeah, that's what I said. Where's his eyeball? Who knows? It's somewhere in there. So we did CT scans. This was back in the 80s, when I did my residency. And so, MRIs were just coming out, so the CTs were readily available. So I don't have any MRI images of it. But you can see the lesion. It's definitely in the orbit. There's the eye. It's hard to tell if the eye is intact or if it's invaded into the eye or not. And the other thing is, you could see it's even in the sinuses. So we called the ENT residents, and they were salivating. Oh, this is going to be a lot of fun. So this turned out to be basal cell carcinoma, just to show you that not all basal cell carcinomas are just small little rodent ulcers. If you let them go long enough, they definitely cause a lot of local invasion and damage. And the whole idea is to basically get it when they're small, not when they're big like this. So
Leo, did you say how long that had been there or been growing?
I
Do you
did
know?
not, and I'll be honest, I don't remember, but I think it's been for, it was like going on the second year or something like that. And
I remember during my residency, I saw something very similar on an older woman, and she had let it go for 9 years. And I remember I walked into the room, and at PCO, you walk in behind the patient, and I just saw the back of the back of the chair and a semicircle of people just filling the room. And in the middle was our oculoplastic surgeon with his hand up to his face saying, I don't even know who to ask for help.
Well, this person needed, we wound up doing an exoneration, which is you go in and you remove the eye, you remove everything from there. And of course, he had extensive sinus surgery also. By the way, we worked him up for metastases, right? What do you think? Do you think he had metastases, Joe?
I'm going to say maybe not.
He did not. It's like amazing. That, remember the earlier slide, that's usually 1% or less of the basal cells ever metastasize. Even when they're gigantic like this, it's just local destruction of the tissue. But it did not metastasize. And just to answer, we didn't have them back then, but now there are certain medications out there that if this kind of patient would come into our office today, we would consider prescribing one of these drugs first. They work through this hedgehog pathway inhibitor system, and basically they're used for either locally aggressive basal cell carcinomas, like what this gentleman has, or metastatic disease. And they've been shown that they can shrink many of these tumors down to a more manageable size, and then you can go ahead and do your surgery. Or if they're smaller to start off with, it's possible to go ahead and even eliminate the cancer completely just from taking the oral medication. That first one, Araveg, I think is used more for people that have had surgery or other therapy for their tumor, but the tumor is aggressive and coming back. And the Odomzo is actually also approved for new tumors like this gentleman who would have come in. You don't have to worry about doing the excision first. You could try the medication, see if you could shrink it down. So it depends on which medication we're talking about. There may be others out there that are available at this time also. So today we have more things that we can work with that were not available back in the 80s and the 90s. So the next most common cancer of the eyelids and the periocular area, although much, much less than basal cells, is squamous cell carcinoma. And this is the one that has a greater chance of metastases and being much more lethal for patients. One of the things I'd like to point out is its most common initial presentation is the lower eyelid medial canthus area. So it's the exact same most common location where basal cell carcinomas are often seen. So be careful, in that area, they're not all basal cells. They could be squamous cell. And remember, we talked about actinic keratosis or solar keratosis, that about 2% of those will evolve into squamous cell carcinoma. So those, unlike sebaceous keratosis, those you always have to excise and send in. Although I can't tell the difference, so I send all of those in. So these squamous cell carcinomas can cause damage by direct extension, but they also can travel along the nerves. They hit the lymphatics and they get into the bloodstream, and that's how they metastasize elsewhere. This is a patient that you may want to check, preauricular or submandibular nodes to see if there's any nodes there, if there's any lymphatic involvement. Basal cell carcinoma, you wouldn't expect to see that, but if you're starting to feel nodes, what looks like a basal cell, maybe you're actually working with a squamous cell. So again, there's all these little tips and hints that you can do to try to parse it out and pare it down. So here's a patient of mine. This lady was sent to me by her family medicine doctor. She lives in a nursing home. He's tried lubricating drops, lubricating ointments. He's tried various types of antibiotic eye drops for this unilateral red eye that just isn't going away. And when I take a look at her, I could see that her lid here is, she's got ectropion, of course, but the lid is also indurated, and you could see some contracture, and she's got this lesion here also on the skin. So I tell this lady, I think you have something there. We need to biopsy and see what we're working with. I honestly don't know what it is, but it looks like it's a little bit aggressive. And so she's 88 years old, and she looks at me and she says, I'm old, leave me alone, I'm gonna die. So, we can't take a hammer, hit our patients over the head and drag them into surgery. So I left her alone. Within 4 months, she comes back to see me. The nursing home sends her in. So this is definitely aggressive, as you can see. This is just a, epithelial mucus plug. That's nothing. But you could see definitely there's more involvement. The lid's more involved, and she's got this thing protruding here. So finally, I convinced her that we need to find out what this is. So I talked to the plastic surgeon that's in the same, works with me all the time, and he took a look at her, and we decided to take her in for frozen section excisional biopsy. So frozen section means that we let the pathologist know we're doing a highly suspicious tumor excision, and we want the pathologist to, we're going to excise it. We want the pathologist to check the borders right then and there for us to let us know if we need to get more borders, keep on going, or if we got all of it. So you would do this at highly suspicious lesions. So we excise the area. There goes most of the lid here, the medial aspect of the lid. And so we excise this area. Usually on a sterile drape or something like that, we draw the orientation for the pathologist, so the pathologist knows which side is up. This way you don't have to put any sutures or anything in it. Essentially we cover it up with a sterile drape, and the circulating nurse will take it to the pathology department. The pathologist is on board waiting already to do this. So what they'll do is they mark all the edges with different colored ink, and then they sort of freeze dry it. And then they take little slides, the little pieces of the tissue out and put it on slides. They look at it under a microscope, and they tell you right away, yes, you got all the cancer on this border, or no, there's still involvement. So when we got the call back, usually it's within 20 minutes, you get the call back, and he said, all the borders are involved. So obviously we had to keep on cutting. At this point, I let the oculoplastics guy take over. I should say the plastics guy take over. My job was to protect the eye so that he didn't take the eye out by mistake, and to keep it moist at this point, because even the lacrimal system's gone. There's nothing for me to do much here. So there's the orbital rim. And finally, when we got to this part, and 3/4 of the eyelid, lower eyelid is gone, and even a little bit of the upper eyelid is gone. Finally, when we got to this point, it was like we got all the borders. Great. So the plastic surgeon wanted to set up a time with her to do a reconstruction. So she looks at the plastic surgeon and she says, "I'm old. Leave me alone. I'm gonna die." So we just packed the area, told the people at the nursing home what they need to do to change the bandages, and there's really nothing else that we were going to do, because she didn't want anything. So she returns to see me again, and this is several months out again, I think closer to 4 or 5 months or so out. Nursing home brings her in. And obviously, although the pathologist told us we got all the borders were clean, somewhere there was still tumors. And this was squamous cell carcinoma, by the way. That's what the final pathology report was. And you can basically see that it's, all this area is indurated. So if you were to palpate it, it's hard as a rock. So this tumor is everywhere. And somewhere in here is the eyeball. It looks like it's still intact over here, but that's what it looks like to me over there. So it doesn't look that intact. And here's the CT scan. That's our original surgery right here, by the way. So you could see that it's infiltrated into the sinuses. It's even gone into the brain a little bit. So it's definitely metastasized. And it was winter, so she's wearing her knit hat. The person that came in with her lifts up her hat and says, "Oh, by the way, she's got this thing on her forehead too." So, I just drew a little circle where I thought the edge of it was. You could see it's also infiltrated in the same tumor is now in the skin of her forehead too. And so we did nothing because she shortly passed away after that. But just to show you how aggressive these tumors could be, and even when we did everything right, obviously there was still some cancer behind. That's why you really want to get the cancer out so it does not come back.
Hey, Leo, real quick question. Somebody asked the difference between the frozen section versus Mohs.
Okay, so Mohs is a tissue sparing procedure. So there you already sort of know what your diagnosis is. you're working in an area that's a delicate area, let's say around the lacrimal gland, the canthal regions, the nasolacrimal duct or so. You want to spare as much tissue as possible. They're doing small little slices, not to take off a lot of tissue. In these types of patients, basically, the tumor we thought was already very extensive. So there's really not going to be a lot of tissue sparing in those types of situations. So you're going to really want to go in there and you're going to take big swaths of tissue out. And basically, when you're doing Mohs procedure, they're also checking those the thin specimens that you're sending in right then and there, because that's how they know if they need to take more out. It's just the difference is the technique. One is tissue sparing. The other is you go in and you're just going to take out all the cancer right then and there as much of it as possible. And you're not really worried about saving any tissue because it's already mostly looks like it's destroyed. I don't do Mohs. Usually it's oculoplastics or dermatologists would do Mohs procedures. Oculoplastics for the eyelids. So sebaceous gland carcinoma is another pathologic malignant lesion, very rare. I will tell you, this is something we're all taught to be afraid of. I have never had a case of this. I've never seen a sebaceous gland carcinoma. It is known as the great masquerader for eyelid cancers. It's very commonly seen in people who have recurrent chalazion. So people think it's a chalazion, they remove it once, it comes back a second time, they remove it a second time, comes back a third time, they remove it a third time, and they can't figure out why they didn't get the chalazion out the first time, when it turns out it's actually a sebaceous gland carcinoma that's just spreading. So my rule is I like doing, I just like excising the chalazion. I think injecting them with Kenalog is perfectly fine also. And I will do that so let's say I do a chalazion excision. I would say 99% of the time that's curative and they never come back. But if they do come back, I'll go ahead and probably do an injection of Kenalog into that chalazion because there must be some inflammation still going on there. If that doesn't work, I'll do another excision, but then I'll send the specimen in. So if you're an optometrist out there that's just doing Kenalog injections, you're never going to be able to get a specimen. Somewhere along the line, you're going to need a specimen just to rule out sebaceous gland carcinoma if you have a constantly recurring chalazion in the same location. So be careful of these. I've never seen one, but you don't want to be the one that gets caught with this because this is a very devastating disease because it does metastasize also. And finally, we're going to talk about malignant melanoma here. We're all familiar with that. This is also rare, but the incidence is increasing. This is where your A, B, C, D, E criteria really come in. You could see the asymmetry of the lesion. The border is irregular. It's sort of spilling over into the adjacent tissue. The coloration, a lot of variation in color of the lesion. The depth, or the diameter is usually quite large as it starts growing, and these things are getting worse fast. So this is something that we don't want to miss. And these are the ones that I usually send off. If I think it's a melanoma, I just send it off to oculoplastics to take care of because they're going to need some additional therapy, potentially beyond just the lid surgery itself. So let's look at some surgical techniques here. So pentagonal wedge resection is sort of a workhorse of removing tumors along the eyelid margin. So this was a man that came in to see me. He had this sort of recent onset lesion on his eyelid margin with a dome to it. When I looked at it, I wasn't convinced it wasn't benign. And so I thought it might be benign. I wasn't sure. So I thought I'm going to do an aggressive shave biopsy on this particular lesion. So what I did was I basically injected it with lidocaine to numb him up. And then I took a 11 Bart Parker blade, and I actually didn't just do a perfect shave along the eyelid margin laterally here. What I did was I sort of went a little bit deeper because I wanted to get a little more tissue for the pathologist to work with. I mean, if you send them a little piece of skin that has nothing, it's going to be difficult for them to figure out what it is. So you want to give them something to work with. What you're seeing here is this gentleman is back about a week later, because by now I got the pathology report back and I wanted to see how he's doing. And what you're looking at is there's still some inflammation there. And this black area here, that's char from the previous electrocautery that I applied. So it's still there. So obviously it hasn't filled in. But the bad news was from the pathologist was that it's basal cell carcinoma, all borders involved. So basically, I didn't get the whole thing out and everything, and there's still cancer all around there. So I have to do something to now get that cancer out. So this pentagonal wedge resection works beautiful for eyelid margin tumors. So here I've taken him to surgery. This is IV sedation. I don't put him under general for this, but the anesthesiologist will give them a little more medication when I do my infiltration to numb the eyelid up. What I'll do before I numb the eyelid up is I will use my surgical marking pen and mark around the area I'm going to take out. So remember, you got to go 1 to 3 millimeters outside of where you think the border of the tumor is. So I took a generous 3 millimeters in all directions because I want to get it out. I don't want to have to go back and do more surgery on him. This is just a corneal shield to protect the eye. So when I'm cutting around there, I don't, cut his eye by mistake. So a pentagonal wedge, the base of it is the eyelid margin itself. And then the two perpendicular walls, imagine this is like a house, here's the roof. The two perpendicular walls are through the tarsal plate. Remember, the tarsal plate is the skeleton of the eyelid. It gives us the structure. So you have to go, if you look at this image to the right, you have to take straight scissors and literally cut through the tarsal plate completely. And this is all smudged. I apologize. It sort of disappeared on me. But basically, then you bring the rest of the lesion together. So when you close it up, it sort of comes together real nice. And you're going to bring the edges, you're going to bring the edges of these lesions together. Because when you reconstruct it, reconstruction is just as important as taking the cancer out, because you don't want any step off, you don't want any notching, because again, you want it to look and function like a normal lid when you're done with this. And so you could see here, the whole thing's been removed. I did mark the lateral edge of it with a suture so that it would orient the pathologist and me. And then the pathologist knew ahead of time that we're going to do this as a frozen section, meaning I'm going to take out a wide swath. And it takes about 10, depending what other stuff he's doing, up to 20 minutes, you're basically waiting there. That's why you need IV sedation in these patients, because the patient will get otherwise very anxious. And then when you're standing there talking to the nurses, you don't want them to hear all your lame jokes. And they're not about the patient, but just lame jokes or who the nurse is dating or whatever. So,
hey, Leo, before you get too far, a question came in about the potential spread of the malignant tumor through biopsy, or maybe you don't get everything the first pass. Does that increase the risk of malignant metastasis?
that is a theoretical problem with mostly melanomas. For the other tumors, it's not going to happen. Basal cells, I've never heard of that. And even squamous cells, I've really never heard of that. But malignant melanomas, I would say, have that potential. And that's why if you suspect a malignant melanoma, you really don't want me doing it. I don't want me doing it. You don't want me doing it. You really need to get them to somebody where they have the resources, where they'll get it the first time and get all of it the first time. So for malignant melanoma, the answer is probably yes. That is a concern. But for the rest of these, no. So the way I reconstructed, so actually it turned out I got the whole thing. So the way you reconstruct it is you take dissolvable sutures that you pass through the tarsal plate to bring the tarsal plate together. And again, you want it to be nice and even, nice and lined up. And then you have to reconstruct the eyelid margin. So you put a suture through the gray line, one posterior to the gray line and one anterior to the gray line. And that prevents any step off or any notching. So you want to make sure that's come together. Some people will cut the sutures all the way at the knots so that they don't rub against the cornea. What I do, because I co-manage a lot of these, I'll get referrals from optometrists from like an hour away or so. And I've worked with the other optometrists so they can remove the sutures. So when I'm basically the patient goes back post-operatively, see the OD, they remove the sutures. I give them something to work with so that they're not struggling to try to get these sutures out. So this is just closing the skin. This was the roof of the house, remember? So I brought it together, and these are the tails of the sutures that brings the lid margin together that I just sutured down on the skin. So when I send them off to the optometrist, the patient sees the optometrist in 1 week, 7 days to remove the skin sutures. And then 3 days after that, which makes a total of 10 days from the surgery, to remove the eyelid margin sutures. In this particular case, the patient did have the optometrist remove the skin sutures, but the OD was not available 3 days later to remove the lid margin, so they came back to see me. So basically, you just grasp the tails, you pull on them, and you just cut right along the edge here where the knot is. And there should be 3 there. So you would cut 3 different ones and it comes apart. This is what it looks like. You could see that it's lined up beautifully. There's no step off. There's some gap, a little bit of gap here, but this will just granulate in perfectly. And so the tumor's out. This guy's going to be very happy. All this induration will sort of disappear because it's secondary to inflammation. And he's not going to have any scar tissue. He's going to look really good. So this is a good workhorse procedure for those types of eyelid margin tumors. Now, what happens if you wind up having to take off like most of the eyelid? Well, now you're not going to be able to bring the edges together. They're just not going to come together on you. So you need to mobilize tissue. And in this situation, you do what's called a lateral cantholysis. So what you do is you take straight scissors and you basically cut the crus. The crus is the connection, the fibrous connection between the superior and inferior lid laterally here. And you do basically a lid splitting where you split the superior and inferior lids apart. And you can see right here, I'm trying to see if I could mobilize it. And it doesn't look like it wants to go. So I may have to move some more tissue. So this is the semicircle of Tenzel. So what you do is you draw this little semicircle into the upper lid. And you're going to make an incision through here, undermine. And then this whole area will then rotate medially. And you could see you could bring it together and put it back together that way. And this is 10 days out. The patient came back to see me. You can see the skin sutures are gone. I just took out the eyelid margin sutures. And there's a little bit of irregularity here, but all this will fill in. The edema will go down. It'll look great. And the next thing I'm going to do on this guy or girl, this I think was a female, I want to do a blepharoplasty on this patient because this has got to go. And I'm going to talk her in. I think I talked her into a nice blepharoplasty also. But that's the problem. Excising something is one thing, but you have to know how to put it back together. And this was a frozen section, and I had to take off more tissue than I anticipated. And then you're not going to leave the patient this way. You have to know other things to do to be able to put them back together. Another poll question. All the previous oculoplastic surgeries that we just talked about should be done with intravenous sedation. A is true, B is false.
Poll question is up. And we're getting down to about our last 3 minutes here, Leo.
Any other questions, Joe, while the poll is
No,
rolling in?
we're caught up.
Things are rolling in nicely. Well, Leo, to save some time here in the polling, to give you some time to wrap up in this next 3 to 4 minutes, looks like it's kind of a tie, but we'll let the audience that has weighed in already. It's 44% true, 56% false.
Well, I personally always use intravenous sedation on the last cases we were talking about, because you don't know how long you're going to be waiting for the pathologist for those frozen sections to tell you what's going on. And what if the borders are involved? You have to do more cutting, and that's going to mean going back to the pathologist, and it could turn into a lengthy procedure, and the patients get very anxious. And so I find that intravenous sedation in these procedures really does help. And just like you said, to wrap things up, and just to show you some, this is, you can see, this is general surgery on this gentleman. This was a basal cell tumor that was causing mechanical ectropion involving a large area. This I did with the plastic surgeon, because basically we knew we were going to take off the whole lower lid. So there's no lower lid to work with. So we're going to have to mobilize tissue. The tissue here along your cheek area is mobile, especially in older patients. And you could see under frozen section, we kept on going and took off not only the whole lower lid, but a whole bunch of area here too, into the maxillary area too. And this tumor was even attached to the orbital rim. So after we excised it from the orbital rim, we use a little instrument to basically shave off some of the bone, because you don't know how far into the bony tissue it went by itself. So here, this is called just the flap advancement, and that incision was made and undermined, and this tissue then is essentially rotated to form a lid, a lower lid. It's not going to function like a lower lid, but at least it'll look cosmetically good. This guy has basically got half a facelift, essentially. And so these kind of surgeries you want to do under general. And then just to wrap it up, the rhomboid or Limburg flap, this is in areas where there's not easy to mobilize tissue, like for instance, in the temporal area of your scalp. So this is a tumor right here, basal cell. You do a rhomboid type of diagram around it, and you're going to wind up matching this line to this one, and this line length and dimension to this one, undermine the tissue and rotate it in and put it back together. And these are always I always feel great after doing these types of procedures, because they're fun, and they're complex. After you've done thousands of cataracts, it gets a little boring. So these are always a little bit of a grab bag. You don't know what you're going to get. This is just showing a lesion I took off in the medial canthus. It was a basal cell, and rotated superior and inferior tissue together medially. So I'd like to wrap it up and thank everybody. This is myself. This is a while ago. This is my wife with me. I'm a poor ophthalmologist, so I can only afford to drive older vehicles. This picture was actually taken by one of the optometry students that rotates with me. And these are some of our children, our quadrupeds. I'm Ukrainian, and so I've been to Ukraine multiple times, done surgery there, lectured in Ukrainian. It's a real language, even though Putin says it's not. But basically, these are rescue turtles from Chernobyl. I didn't know they were going to grow that big. I suspect they may have been exposed to some radiation, but they're very friendly. And if I tell the students that if you're not nice to our quadrupeds, they're going to eat you. So
very awesome.
So I'm done unless there's
Okay.
any additional questions.
Yeah, Joe, are there any questions right now?
There are not. But Leo, I want to thank you for doing that. That was fabulous. Very, very interesting.
So with that being said, there should be a little red dot on your screen right here, and you can start that survey that I told you that would start about 9:50 Eastern time. So there's a little red dot. Click on that. You can start that survey. You don't have to wait till 10 or Eastern or wait for the email. Joe mentioned that there are no more questions. I want to thank everyone for attending Extreme Dermatology. Leo, any final comments before we end the education?
I just want to thank everybody for putting up with me for almost 2 hours. And I thank you for the questions. I'm sorry I didn't know the answers to some of them, but I don't want to make things up. If I don't know the answer, I'd rather just say I don't know the answer. In my arena, I have a lot of other experts that I can draw from and send patients to. And so I don't necessarily have to know all the answers versus if you're a private practitioner, you have to know everything.
Well, I'll echo what Joe said. It was a fantastic lecture. And that will conclude Extreme Dermatology. Thank you.
And you're getting your virtual round of applause from the audience surveys. Thank you and telling you it was an amazing lecture. And we would concur.
Thank you all and have a good night.